Good morning, respected teachers and colleagues. So today's debate is on 3 weekly versus weekly cisplatin with RT in the postoperative setting for head and neck cancers. So for 3 decades, cisplatin has been used in the management of locally advanced squamous cell carcinoma of the head and neck to enhance the tumoricidal effect of irradiation. There exists level 1 evidence for a significant improvement in locoregional control and or overall survival with 3 weekly high-dose cisplatin concurrently with conventional external beam RT compared with RT alone. So if we look at the existing literature, so there are 4 large phase 3 trials from 2003 to 2004, which have studied 3 weekly cisplatin concurrently with RT. These studies have uniformly found significantly improved disease-free survival, locoregional control, and overall survival with high-dose 3 weekly cisplatin. Additionally, 2 large phase 3 trials, that is the RTOG 1016 and the de-escalate, have compared high-dose 3 weekly cisplatin with RT to bioradiation with cetuximab and RT and have found unequivocally better locoregional control rates and survival rates. So, taking an additional supporting data from yet another smaller randomized study from 2004, we have a total of 7 trials that consisted of a total intention to treat population of up to almost 3,000 patients. So, coming to the individual studies, so this study was by Cooper et al., which included 459 patients, and the dose of cisplatin that was used was 100 mg per meter square of DSA at a 3 weekly regimen. So this found significantly higher rates of local and regional control as well as disease-free survival in the combined therapy group. So coming to the next study, this was by Bernier, the EORTC trial 2200-931. So the dose used here again was 100 mg per meter square of cisplatin per BSA. And this also found significantly improved PFS and OS. So PFS was, the median PFS was 47% in the combined therapy group and 36% in the RT group. And for OS, it was 53 versus 40%. So coming to the toxicity analysis, so this study also found that the cumulative incidence of late complications was actually not significantly different between the 2 groups. So some of these late complications that were included xerostomia, impairment of lymphatic drainage, laryngeal bone complications, and skin and soft tissue fibrosis. So coming to the next 2 studies that compared cisplatin plus versus cetuximab with RT. These were both positive trials, and it is important to note that the de-escalate trial also found a significant decrease in distant mets after cisplatin treatment. So the rate of distant mets had reduced from 9% to 3%, which was statistically significant. So this is an overview of the existing randomized trials on 3 weekly cisplatin. The intention to treat population, as we see here, is reasonably large, and the data is also quite robust here. In contrast, if we look at the existing literature on weekly low-dose cisplatin, the population that has been studied is significantly smaller. It's 834 according to this overview, and the data also appears less robust. So coming now to another systematic review that studied cumulative cisplatin doses in concurrent chemoradiation for head and neck cancers. So this study found a significant improvement in OS that was noted with increasing cumulative cisplatin doses. So there was a 2.2% absolute benefit in OS, which was found between the combined therapy arm and the RT only arm that was observed for every 10 mg increase in the cumulative cisplatin dose. There are also some trials where a substantial fraction of patients could not receive the 3rd planned cisplatin dose of the 3 weekly cisplatin regimen. This suggests that a cumulative cisplatin dose of approximately 200 mg per meter square, independent of the schedule, may be sufficient to yield a beneficial anti-tumor effect. So next week, we come to this systematic review and meta-analysis. So this study, this looked at studies comparing weekly low dose versus 3 weekly high dose cisplatin for concurrent CTRT. So the conclusions of this study were that although there was not a very clear difference in the survival between the two groups, keeping in mind the lack of support for low-dose weekly cisplatin and control trials, the authors were concerned about its indiscriminate and premature adoption in routine clinical practice. At the 2015 annual meeting ASCO, there was also expressed a need for caution before adopting low-dose weekly cisplatin as a treatment standard. So they suggested that a significantly higher total cumulative dose that was reached with a high-dose regimen versus the low-dose weekly regimen could be reached with a potential impact on overall survival. So next we come to a phase 3 randomized study by San et al., wherein 55 patients with high-risk squamous cell carcinoma of the oral cavity were included. The doses that were used, this was a study design, so patients were randomized to either concurrent chemoradiation with high dose or low dose cisplatin. The high dose that was used was 100 mg per meter square every 3 weeks, and low dose was 40 mg per meter square weekly. So the adequate cisplatin dose, which as we saw earlier is defined as a cisplatin dose of more than of at least 200 mg per meter square, was seen in more patients in the arm A, that is the 3 weekly arm, in comparison to the arm B, that is 88.5% versus 62.5%. This study also actually found an overall toxicity that was significantly greater for patients in arm B. All grade 4 toxicities that were seen were observed in arm B, that is the weekly arm, which included 3 cases of pharyngitis, 2 cases of stomatitis, 1 case of nausea vomiting, and 1 case of laryngeal edema. The weekly arm also showed a greater incidence of mucositis of grade 3 and above. There was also no difference found between the groups in terms of compliance. So this was also the first trial to compare health-related quality of life between the two groups. So the study found that for the weekly regimen, the physical well-being of patients decreased more significantly. That is, it became worse in comparison to patients in 3 weekly regimen at each time point that was analyzed. So this greater decrease in physical well-being probably also reflects the greater levels of acute toxicity that was reached in the weekly arm. Next, we come to a study from our center by Vanita ma'am and Kumar sir and colleagues. So this was once a week versus once every 3 weeks cisplatin chemoradiation for locally advanced head and neck cancers, which was a phase 3 randomized non-inferiority trial. So this was a study design. Patients included were less than 70 years with squamous cell cancers of the oral cavity, pharynx, larynx, or cervical lymph nodes of unknown primary, stage 3 or 4. Both adjuvant as well as definitive setting was included in the study. And if patients were post-op, high-risk features included EC close or positive margins, T4 primary, or at least 2 positive lymph nodes. So patients were stratified as per T stage, as per N group, and as per therapy intent, and they were randomized in a 1:1 ratio to 3 weekly cisplatin at a dose of 100 mg per meter square and weekly cisplatin at a dose of 30 mg per meter square. So this found a significantly better median 2-year locoregional control rate with the 3 weekly cisplatin group, that is 73.1% versus 58.5% in the weekly arm. The median OS was not reached in the once every 3 weeks arm, while in the 39.5 months, while it was 39.5 months in the once a week arm. So there was actually a trend towards improvement in PFS and OS in favor of the 3 weekly regimen, but this was not statistically significant because the study was powered only for locoregional control. Coming to the toxicity analysis, so although the toxicities were high, most toxicities abated. The rate of severe chronic toxicities was actually low. So although there was a high rate of severe acute toxicities, this did not compromise compliance. So the uptake was also good. So in the sense that in the EORTC trial, only 79% patients received at least 2 cycles of chemotherapy, in comparison to 95% patients in the 3 weekly cisplatin arm in this study. So the compliance to therapy in the 3 weekly cisplatin arm was also not significantly different from that in the once weekly arm. The overall compliance was excellent at 91.3%. Now, finally, we come to this study, the weekly cisplatin plus radiation for post-op head and neck cancers, the JCOG 1008. So this is the first and only phase 2-3 study that has shown non-inferiority of weekly cisplatin with RT regimen in comparison with 3 weekly with RT in the post-operative high-risk setting. So an important limitation of this study is that the study had a relatively wide non-inferiority margin of 10% for 5-year overall survival, corresponding to a non-inferiority margin of hazard ratio of 1.38. So in practical terms, this would allow for a possible 32% increase in risk of death in chemoradiation with weekly cisplatin. This may not be acceptable in a curative setting. So, so coming to conclusions, so as we saw here, the 3 weekly cisplatin has significantly more robust data for survival and locoregional control. Although toxicities are a concern, there has been no significant increase in late adverse toxicities that were noted, no significant difference in compliance that was also noted in the studies that we saw. A 3 weekly regimen could potentially put a lesser burden on daycare facilities and reduce OPD visits. We also have health-related quality of life data, as we saw in the study by San et al. Thank you.
Thank you, Laboni. Now, Devanshi will hand over to Devanshi for her debate on the use of weekly cisplatin in the concurrent with that.
Good morning, everyone. So I will be betting for weekly cisplatin in locally advanced head and neck squamous cell cancers. So indications of adjuvant RT in locally advanced head and neck squamous cell cancers are close or positive margins, extracapsular extension, any nodal involvement, invasion of soft tissues of the neck and lymphovascular invasion, PNI, T3 or T4 tumors greater than 5 mm subglottic invasion. So 60 gray in 6 weeks to 66 gray in 6.5 weeks is standard for patients with negative margins and fewer than 3 indications for RT. And for patients with close or positive margins, 70 gray in 7 weeks or 74.4 gray at 1.2 gray twice a day is standard. Indications for adding chemotherapy to adjuvant RT in locally advanced head and neck squamous cell cancers is mainly 2 indications, extranodal extension and positive margins. Additional indications are close margins, T3 or T4 primary, N2 or N3 nodal disease in levels 4 or 5, and PNI vascular invasion or lymphatic invasion. Last few indications are not category 1 indications. So meta-analysis of chemotherapy on head and neck cancers, that is MATCH and NC, included 63 randomized trials published from 1965 to 1993, in which compared locoregional treatment with or without chemotherapy. The absolute improvement in 5-year OS was 4%, which was statistically significant. And in this subgroup analysis was done, which showed significant improvement in patients who received concomitant CTRT rather than induction or maintenance chemotherapy. So in only this subgroup, this concomitant group, chemotherapy had statistically significant improvement in overall survival. So the role of systemic therapy, RT, in postoperative management of patients with adverse prognostic risk factors has been clarified by 2 multi-center randomized trials, which are RTOG 9501 and EORTC. So RTOG 9501 randomly assigned patients with 2 or more involved nodes, positive margins and extracapsular nodal spread of tumor to receive standard postoperative RT or RT plus cisplatin, which was 100 mg per meter square every 3 weeks for total 3 doses. This trial showed statistically significant improvement in locoregional control and DFS, but not in overall survival. EORTC 22931 trial used the same chemotherapy regimen and similar RT dosing, but also included high risk factors like the presence of PNI vascular invasion or nodal involvement at levels 4 and 5 from the oral cavity or oropharyngeal cancer. This trial found significant improvement in survival and the other outcome parameters. However, there were few concerns like insufficient compliance and high dose related toxicities. So like only 60% of patients completed total 3 cycles of cisplatin, and major toxicities were neutropenia, infection, renal impairment, hearing impairment, etc. Combined analysis of prognostic factors and outcomes from RTOG 9501 and EORTC 22931 trials was performed, which showed that patient in both trials with extranodal extension or positive margins benefited from addition of cisplatin to postoperative RT. For those with multiple involved regional nodes without without external extension, there was no survival advantage. Randomized trials and meta-analysis showed significantly improved OS, DFS, and locomotor regional control when systemic therapy and RT were given concomitantly, and was compared with RT alone for locally advanced disease. But however, limited data is available for comparing the efficacy of different chemotherapy regimens. So currently NCCN recommends in adjuvant setting preferred regimen is cisplatin, which is category 1 recommendation for high risk non-oropharyngeal cancers. Weekly cisplatin plus RT is widely used as a possible alternative for adjuvant high risk squamous cell head and neck cancers because it has a radiosensitizing effect during RT and higher doses intensity of weekly rather than 3 weekly schedule, which is weekly is given 40 mg meter square versus 3 weekly. If we calculate weekly dose of tentative weekly dose of 3 weekly cisplatin, which comes around to 33 mg per meter square per week. So superiority of weekly cisplatin plus RT to RT alone was suggested in postoperative high-risk squamous cell head and neck cancer, and it has safety advantage over 3 weekly cisplatin plus RT. The superiority of weekly cisplatin plus RT to RT alone was shown in trial by Bachod et al. In Radiation Oncology Journal. So coming to our data, which was published by Dr. Vanita ma'am and team, which was once a week versus once every 3 weeks cisplatin concurrent with RT in locally advanced head and neck cancers. It was phase 3 randomized non-inferiority trial. It randomized, it was a single institution trial. In this, patients were randomized to cisplatin 30 mg meter square weekly versus cisplatin 100 mg meter square every 3 weekly. Total 300 patients were enrolled and 93 of them were in adjuvant setting. 2-year locomotor regional control was superior in patients who received cisplatin every 3 weeks, which was 73%, compared to who received weekly cisplatin, which was 58.5%. P-value was 0.01. However, a patient randomized to receive cisplatin every 3 weekly developed more severe toxicities, 85% versus 71%, and which was also statistically significant with p-value of 0.006. The most common acute adverse events were hyponatremia, leukopenia, neutropenia, and lymphocytopenia. And p-value for all of these adverse events was less than 0.001. So weekly cisplatin at dose of 30 mg meter square plus RT failed to confirm non-inferiority to 3 weekly, but however had a fewer toxicities. Majority currently there is no till recently there was no phase 3 trial comparing weekly 40 mg meter square versus 3 weekly 100 mg meter square for post-operative high risk squamous cell head and neck cancers. The median 2-year locomotor regional control rate in patients treated with once a week cisplatin was 58%, while it was 73% in 3 weekly cisplatin. And the absolute difference in locomoregional recurrence rates between two arms was 15%. The median PFS of the patients in once a week arm was 17.7 months, which was 28.6 months in once in 3 weeks arm. The median OS of the patients treated in once a week arm was 39.5 months, and median OS has not reached in patients treated in once in 3 weeks arm. However, the toxicities like grade 3 toxicity, grade 3 toxicities, hospitalization, and use of growth factors all were significantly high in 3 weekly cisplatin arm, and all were statistically significant with p-value of less than 0.01%. So definitely 3 weekly cisplatin was more toxic. Hematological toxicities like leukopenia, neutropenia, FN, thrombocytopenia, and lymphocytopenia were also higher in 3 weekly arm. Among grade 3 non-hematological toxicities, vomiting, hyponatremia, and deafness were significantly higher in 3 weekly cisplatin arm. Chronic toxicities, however, were similar in both the arms. Now coming to our trial recently published, JCOG 1008 published in March 22 in Journal of Clinical Oncology. This trial studied weekly cisplatin 40 mg/m² plus RT for postoperative head and neck squamous cancer. And it was also it was a multi-center non-inferiority phase 2-3 randomized control trial. So trial design was 28 institutions participated in this trial. Post-operative high-risk squamous cell cancers, like enrollment criteria for the trial included pathological stage 3 or 4 disease, microscopically positive margins or extranodal extension, oral cavity, larynx, oropharynx, and hypopharyngeal cancers. Randomization was 1:1 in either 3 weekly cisplatin plus RT, which was 100 mg/m², or weekly cisplatin plus RT, which was 40 mg/m² weekly. So objectives and endpoints was of the studies were it was in phase 2 part. The aim was to study the feasibility of both the arms, and primary endpoint was proportion of treatment completion, which was in arm A more than 2 cycles and in arm B more than 5 cycles. The phase 3 part, the main aim was to test the non-inferiority of weekly cisplatin plus RT versus 3 weekly cisplatin plus RT. Primary endpoint was OS, and secondary endpoints were relapse-free survival, local relapse-free survival, nutrition support-free survival, non-hospitalized treatment period, and adverse events. So patient characteristics, patients were matched in age, sex, ECOG performance status, primary site, and high-risk factors in both the arms. However, however, in this trial, the plus point was that high T4 and T4 disease, higher number of patients had T4 disease, higher number had N2, and higher number had stage 4 disease. Interim analysis. So phase 2 part, in first interim analysis, the DSMC allowed to continue phase 3 part because of the confirmation of feasibility of both the arms in 2015. And phase 3 part, first and second interim analysis. In first interim analysis, it was planned when half of the sample size was registered, and second interim analysis was planned after accrual completion. DSMC recommended terminating the trial early and publishing the results because of statistical boundary for non-inferiority of OS had met the specified stopping criteria. Oral survival. So in terms of OS, weekly arm was non-inferior to 3 weekly arm, and relapse-free survival. So in relapse-free survival, weekly cisplatin and 3 weekly cisplatin. So now number of events were less in weekly cisplatin, and 3-year RFS rate was 64.5% compared to 53% in 3 weekly cisplatin with hazard ratio of 0.7. Local relapse-free survival was also higher, which was 69.6% in weekly cisplatin arm and 59.5% in 3 weekly arm with hazard ratio of 0.7. So now coming to OS in per protocol subset, the OS was 72% in weekly cisplatin arm and it was 60% in 3 weekly cisplatin arm with hazard ratio of 0.6. The median follow-up period for this analysis was 2.2 years. Now coming to subgroup analysis for OS. So 3 weekly cisplatin was weekly cisplatin was better in all the subgroups, majorly primary site, which was oropharynx, hypopharynx, laryngopharynx, oral cavity. The weekly cisplatin was better. High risk factors like in high risk factors like external extension or incomplete resection, the weekly cisplatin was better, and overall also the weekly cisplatin was better compared to 3 weekly cisplatin. Now coming to toxicities, total considering toxicities, both the arms were comparable except that thrombocytopenia of any grade was frequent in 3 weekly arm, and grade 3 or less neutropenia, grade 3 or more neutropenia was less frequent, which was only 35% compared to 48% in 3 weekly arm. Non-hematological toxicities. So weekly cisplatin plus RTM was better in terms of non-hematological toxicities like dysphagia, nausea, infection, hyponatremia, renal impairment, hearing impairment. And 3 weekly arm had significantly higher toxicity in this categories. So to summarize, phase 2, phase 3 study of weekly cisplatin RT plus 3 weekly cisplatin RT met its primary endpoint of non-inferiority in OS with hazard ratio of 0.69, and one-sided P for non-inferiority was 0.0027. Better relapse-free survival for weekly cisplatin plus RT, better local relapse-free survival for weekly cisplatin RT, and favorable safety profile of weekly cisplatin plus RT. So there was decrease in incidence of neutropenia, dysphagia, nausea, infection, hyponatremia, renal impairment, and hearing impairment. So to conclude, this phase 2, phase 3 study is first to show that weekly cisplatin plus RT is non-inferior to 3 weekly cisplatin plus RT in postoperative adjuvant setting. Weekly cisplatin plus RT is new standard of treatment option for these patients, and final analysis is planned after 5-year follow-up from final registration. Now coming to previous data in post-operative high-risk setting, there were few studies which studies by Cooper et al. And Bernier et al., which studied 3 weekly dose of cisplatin with event-free survival and OS of 47 and 46% respectively in Cooper et al. And 47 and 53% respectively in Bernier et al. Weekly cisplatin was studied in Bachod et al., Rampino et al., Poseidou et al., and Otis et al. Studies. The Bachod studied 50 mg per meter square dose, and it had event-free survival of 45 and OS of 36% at 5 years. And except this 50 mg dose, the Rampino and Poseidou Rampino studied 30 mg meter square of cisplatin weekly dose, and which had event-free survival and OS of 62 and 63% at 5 years respectively. The Poseidou and Otis study also reflected similar results. So to summarize, weekly cisplatin is not inferior to 3 weekly cisplatin, and it has a favorable safety profile. So which can be especially beneficial in head and neck patients which have poor nutrition, which are compromised, which patients are compromised in nutrition, compromised nutritionally, and PS may not be that great. Thank you.
Thank you, Devanshi. Laboni, would you like to say something as a rebuttal?
Yes, ma'am. So as Devanshi pointed out, although there is this one study that was that shows that it was non-inferior, still considering the significant robust data that we already have for 3-weekly cisplatin, it may be still premature to consider weekly as a standard of care, and as I mentioned, for this study, the non-inferiority margin was also quite wide. So, so that 1.32 hazard ratio was, I mean, whether it is acceptable or not is, I mean, it may not be acceptable. It was really wide, and it would allow for a 32% increase in death. So. Also regarding toxicity profile, yes, there is, the incidence of acute toxicities is higher, but there is also some data to also suggest that the risk of chronic toxicities is similar, and also the compliance rates are also similar between the two groups.
Thank you, Laboni. Devanshi, do you like to reply to what Laboni has said? Your comments?
Yes, ma'am. So this cisplatin, first of all, cisplatin 40 mg meter square dose was not previously studied in phase 2, phase 3 trials, and to consider cisplatin 100 mg meter square as superior or cisplatin 40 mg meter square superior, we'll need superiority trial design based on superiority pattern. So I think we cannot comment that either one is better, but we can consider 40 mg per meter square without any doubt in mind for few patients who are not in great shape and who are nutritionally compromised, and I think which would include more than 60% patients of head and neck cancers.
Thank you. There is a question for Laboni on the chat. Lingrat sir has asked, what do you think should have been the non-inferiority margin for the Japanese study acceptable for us? And how would you determine that margin? So Laboni, would you like to take that question? We had this discussion last week during the journal club. Laboni? Devanshi, would you like to take the question?
Sorry, hello.
Okay, Laboni, go ahead.
So, acceptable margin, actually, I'm not sure actually.
Lavani, you said 10% was a wide margin, right? 10% was the margin in Japanese study.
Yes, sir.
Am I right? Yeah. So, how do you determine non-inferiority margin? Do you have any idea? Like how they have taken any random number 10%. So, in a study, how do you determine? Okay. So, what do you think would have been the acceptable margin? So, who has shown the McKenzie meta-analysis? I think Devanshi has shown.
Yes, sir.
Yeah. So, what was the absolute improvement in overall survival with concurrent cisplatin as opposed to RT alone?
Sir, in overall group, it was 4% improvement in overall survival.
And that was mostly with concurrent.
Yes, sir. Mostly with concurrent, which was 8% for concurrent group.
For concurrent group, it was 8%.
Yes, sir.
Yeah. So I think that's how they determine, when you determine the non-inferiority margin, you have to see what was the absolute benefit with that intervention and how much loss is acceptable to you if you are going to change the regimen or to make it more patient acceptable in terms of toxicity. So that's how we have to determine the margin. And if it was 8%, whether it was okay to take 10%, I think that we have discussed also last time in the last channel club also in this study was discussed. So that is something to keep in mind, that when you determine the margin, you have to see what was the absolute benefit, and you have to take a margin based on that.
Yes.
Yes.
There is another question on the incidence of AKI weekly versus 3-weekly. Devanshi or Laboni, anyone if you can take.
I think she's already answered. I think Devanshi,
Yeah, 29
versus 39. So what was the non-inferiority margin in our study? This one, the TMH, Vanita's, because of,
Devanshi, would you like to answer the question? Non-inferiority margin in our study. Hello,
Ma'am, I will have to check.
Laboni? Laboni, would you like to take the question? What was the non-inferiority margin in our study on once a week versus once in 3 weeks? Okay, since nobody is answering the non-inferiority margin, ma'am, it was set at 15% in our study because they used the assumption that earlier studies showed an improvement in loco-regional control as 13 to 24%. So 15% was taken as the non-inferiority margin for our study based on previous data.
so if I'm not mistaken, what I understand is that our study had a non-inferiority margin of 15% and the Japanese had it at 10%, right?
Yes, ma'am.
So, and the Japanese study, did it show that it was not non-inferior and ours that it is non-inferior?
Yes, ma'am. That was how it was.
No, ma'am, it was reverse. Our
mean,
study showed it was not non-inferior and Japanese showed it was
Oh,
non-inferior.
sorry, I meant the other way around. Yeah.
Ma'am, our
So-
endpoints were different. In our study, it was loco-regional control was the primary endpoint, and this JCOG 1008 was they took the primary endpoint as overall survival.
So, and in the TMH, is there a difference in overall survival?
Ma'am, there was a numerical difference at the initial thing. Laboni, would you like to go ahead?
There was a trend towards it. It was not reached actually, but it was not powered for for statistical significance.
Sure. Okay, so, and the difference in the Japanese study in the loco-regional control rate? Sorry, did I miss out on all these points and not pay attention? So,
Loco-regional control was the OS, and that was reached. I mean, it was it was non-inferior. The weekly dose was it was inferior to the 3 weekly dose.
no, that is in the TMH study.
Yes, ma'am.
But in the Japanese study also was the difference in, because you said OS, it was not non-inferior in the Japanese study in the loco-regional control, was it not non-inferior? Sorry. I mean, was it, I mean, you can't say whether it was better, but which is the pink one? Weekly, here it is the other way around. Weekly cisplatin seems to be doing better.
Yes, ma'am. In this, they took it as local relapse-free survival, and there also they said that weekly cisplatin was better, but there was a little odd pattern of recurrence. They had a higher incidence of distant mets in the 3 weekly arm, which was not seen in ours.
Okay. It's because it's like the loco-regional control rate seemed to be going just the other way around. I mean, even if it was, the trend was in the same direction, that is fine. But, any thoughts on why that is? Because there's almost like a 10% difference in AKI also.
Yes.
Devanshi, would you like to answer Madam's question? If there was a 10% difference in AKI and weekly showed even a better loco-regional free survival, any explanation, or should we just stick to weekly as a standard of care henceforth?
Ma'am, actually, AKI was higher in 3 weekly. It was 39.5% and in 3 weekly arm and 29.5 in weekly arm.
Any other questions for Laboni or Devanshi? So this the question by Akhil to everyone: the Japanese trial versus our trial. What made the results look different? Both Devanshi and Laboni, can you just comment on this? What was the why did the results? I mean, they are opposite results in a similar setting. So, what are the differences? Why does it look different? What would be your thoughts? What do you think are the possible reasons? I think Laboni go first, and then Devanshi. Laboni?
Hello. In our study, in the TMX study, generally the performance status of the patients was overall better. More than, I think, 90% of patients have had a performance status of at least 1. And also that was one possibility, and they also
So does that mean that those who are ECOG 2 and below?
So they would be likely to tolerate 3 weekly less.
So, and what was the cutoff GFR for the use of 3 weekly? 60%, and if anyone less than that, did you use 3 weekly?
50 was the cutoff that was used.
Okay. And what was the recovery rate of that AKI? I mean, how many did it resolve?
I'll have to.
I mean, did anyone have long-term renal toxicity? Meaning, AKI which is resolved versus any long-term CKD in any of these patients, and what percentage?
Among chronic toxicities, I think I'll have to check, ma'am. I think it's in the supplement.
Devanshi, your thoughts on what made the results look different in our study versus the Japanese study? Devanshi?
Ma'am, so basically, maybe because the patients who were enrolled in the study, they were somewhat different in terms, like a majority of patients in our study was were CA oral cavity cancer patients, and maybe the etiology was different in oral cavity cancers, like P16 positive. This subgroup analysis was not done, but that could be a reason.
Okay. So just to summarize today's debate, it has been a topic of discussion always on the ideal regimen for concurrent chemotherapy, both in the adjuvant and definitive setting in head and neck cancers, whether 100 milligram per meter square versus weekly regimens, which are often perceived as easier to administer. So our study was the designed as adjuvant as well as definitive, but it was 90% or plus patients were in the adjuvant setting, and predominantly, as Devanshi has pointed out, they were all, most of them were oral cavity cancers. And here we did not meet our endpoint of showing that weekly was non-inferior to 3 weekly. So it was a non-inferiority design in our study as well. And our dose was different. We had taken 30 mg per meter square dose, and that was based on a prior study from our setting where RT versus cisplatin 30 mg per meter square plus RT was used, and that's why it was used as the arm, comparator arm. And in the Japanese study, the dose was 40 milligram per meter square. Though there are limitations to the Japanese studies as well as our study, the endpoints are which they have shown are different. They focused on the overall survival. We had local regional control as our endpoint, so which eventually also showed that it probably impacted the local regional survival because there was a trend towards a higher OS, though we are waiting the long-term follow-up results in our study as well. So whether this is practice changing, we had a big discussion at our last journal club on the statistical design as well as the non-inferiority margin and what is acceptable for clinical care. So just to summarize is that probably there is still a lot of debate whether really 40 mg per meter square will be non-inferior to 100 mg per meter square. But the Japanese data gives us some evidence to show that in patients who probably won't be able to receive 100 milligram per meter square, 40 may be an acceptable alternative, provided we know that there are limitations of the study. Also, another thing what we had discussed last time was that if you look closely at the study, the certain subgroups didn't do as well, though Devanshi showed in the forest plot that we all favored the weekly arm. If you look at that, most of them crossed the confidence interval crosses 1, and a lot of them, if you look at the upper limit of the confidence interval for patients with high risk factors such as T4, patients with ENE or incomplete resection, it even goes up to 2 or 2.07. So probably in a high risk group, maybe we have to be a little cautious before we say that 40 mg is truly non-inferior. But on the whole, we could keep 40 mg per meter square as an option in patients, keeping in mind all the other factors. So Ajay madam has put a comment that we could say 40 mg is non-inferior, but not 30 mg per meter square. Agree with madam. Based on the current evidence we have, is that 40 mg is non-inferior to 100 mg per meter square according to the Japanese trial. So it could be an alternative. However, we have to keep in mind the limitations of the study. So with this, I would like to conclude and take comments from Kumar sir and Vanita ma'am if they have any. Kumar sir.
Hi, good morning. Good morning, everyone. So it was a good debate, but I agree with. Can you hear me, Nandini?
Yes,
Yeah.
sir. Yes, sir. We can hear.
So I agree with Dr. Lingaraj. Debate could have been a bit, spicy. Spicy nahi tha. No one made some good remarks. I think so. Maybe we can have some young consultant debate, so they may learn a bit more. But they put the literature well. So I think so. The two pertinent questions were one, why this study was different and what happened to the statistics. So maybe can you help me share the screen? Just getting some ideas that people should know, what are the margins and how we take it, in case they are interested in, and they don't get scared when they see those 15%, 10%, 20% margins in non-inferiority. Can you share the? Can you help me sharing the screen? Okay, बहुत ही बढ़िया. So what I'm doing is I'm taking a surgical trial, and this is again, people will agree, good publication in a good journal. We all read it, and I'll request people to focus on the statistics part. So what margin they took? Again, what is here? It is 15%. This was a laparoscopy versus open surgery. So Laboni, what happened? Did they made an error? Not for debate. So I will also pick up this in debate and ask this question. This is for learning when you want to do a study in your clinic. That is why I wanted to put in. and this is quoted everywhere. This is something which has decided a treatment for laparoscopy versus no laparoscopy. And I'll again repeat, if you give me 10 minutes, then I'll share you half a dozen studies like this. Again, putting it 15% margin. Key is, it is not 15%. There is explanation here that non-inferiority upper limit of 95% confidence interval. It is not absolute 15%. So again, that part we need to again realize and see it in the detail. So if you see the weekly versus 3 weekly, they put absolute 30%, but when they put hazard ratio, that is in Japanese study, that was upper limit of confidence interval is 1.32 or 3.7, whatever they had put in. Same way in our study, it was 15%, 95% of the confidence interval, you do it. And when we say 95% of the confidence interval, means upper limit. If it will come somewhere in between, maybe some 6-7% or 8%, something like that will be the difference. And there was a comment, how do we bring those numbers? There are various ways. I'll share one. Last time I had shared one, and I'll share another way of having your non-inferiority margin. So what you do, you go and see what was the absolute difference. So someone quoted Mac and C. What was the absolute difference? Laboni or Devanshi had quoted. What was the absolute difference in Mac and C? What is the difference between chemoradiation versus radiation and the difference in the outcome? Anyone, either of them?
4% overall survival difference.
Bahut badhiya. So that is, again, I'm repeating my question. Chemoradiation versus radiation, you said 4%. And iska naam kya? Devanshi, what was the difference?
Sorry, sir.
What was the difference between the survival? If you give in head and neck cancer, chemoradiation versus radiation. कोई नंबर नहीं पता यार, तुम हेड नेक पोस्टिंग हो गई तुम लोगों दोनों की?
Sir, 4% was additional gain with chemotherapy was 4%.
Done. Thank you, Devanshi. So let me modify the question a bit. Chemoradiation with cisplatin versus radiation. What is the difference in the survival? Laboni or Devanshi? अरे कुछ बोल नहीं रहे तुम्हें? कोई थर्ड ईयर नहीं हमारे इधर? No third year. Pritesh? Not very tough question. This question will be asked in the exam also. Pritesh is not there.
Yes, sir.
Chemoradiation with cisplatin. What is the difference between the survival versus radiation? But chemoradiation is cisplatin. तुम्हारा भी हेड नेक हो गया, मैं बता रहा हूँ। सारे तुम कलीग्स जो है ना मेरे सोचेंगे पता नहीं ये हेड नेक ओपीडी में मैं क्या कर रहा हूँ। अच्छा, anyone else is there? Can I see someone else? दिख नहीं रहे सब। Third years, anyone? No one wants to volunteer?
Sir, Ashutosh here, sir.
Ashutosh, thank God.
8%, sir. It was
8%. चलो भाई थोड़ा सा फर्क आ गया. So what we heard, Laboni and Devanshi, देखो आशुतोष ने बोला 8%. Is he right? Unless someone wants to debate, we take it. Or Alok, is he right when he says 8% difference in absolute improvement in survival if you give chemoradiation with cisplatin versus only radiation?
Sir, 5-year overall survival with chemoradiation will be 56%. Accelerated RT is around 40%.
अरे नहीं वो पूछे जितनों में पूछ उतना ही पता नहीं। देखो वो तुम ज्यादा बताओगे तो मैं कंफ्यूज हो जाता हूँ, समझते नहीं हो तुम। तो मैं बोला कि कीमो रेडिएशन विद सिस्प्लैटिनम वर्सेस रेडिएशन इन हेड एंड नेक कैंसर, क्योंकि जनरली वहां पे हम क्लबिंग करके देखते हैं. विल कम टू सब ग्रुप एंड अदर्स. गिव मी 5 मिनट्स सो दैट क्या डिफरेंस है. वो 8% बोल रहा है आज, तो सही बोल रहा है या गलत बोल रहा है?
अब ज्यादा बेनिफिट.
क्या बोलो? ज्यादा बोल रहा है वो?
नो नहीं
कम बोल रहा है. हाँ
कम बोल रहा है.
वो कम बोल रहा है और भी ज्यादा है? तुम कुछ नंबर बता दो फिर.
15 to 20. 5 year old.
अभी देखो ये तो बढ़ के, अभी देखो 4% से हम 15 to 16 आ गए अभी. चलो, coming back to Ashutosh, let me modify the statement a bit more. 3 weekly cisplatin with radiotherapy versus radiotherapy. Now what is the difference? Anyone? ये देखो नुकसान है ऑनलाइन का. वो सारे मैं देख ही नहीं पाता हूँ कौन थर्ड ईयर है कौन नहीं है, और कोई वॉलंटियर नहीं. अतुल तुम थर्ड ईयर में हो या सेकेंड ईयर में? हाँ अतुल. अरे रवि इज देयर. रवि रवि 3 weekly cisplatin versus radiotherapy plus radiotherapy versus radiotherapy. हाँ बताओ भाई.
Not sure.
Not sure. और कोई श्योर है? Anyone wants to be bit sure? अच्छा, और मैं किसी को देख नहीं रहा हूँ. चलो बढ़िया. देखो दैट इज इम्पोर्टेंट. हाँ ये सही बोला अखिल ने भाई. स्विच ऑन द वीडियो. अभी थर्ड ईयर स्विच वीडियो तो स्विच ऑन कर लो. अब देखो मैं तो अपना चेहरा दिखा रहा हूँ, नॉट द गुड वन, बट तुम अपना चेहरा तो दिखा ही सकता. राहुल इज देयर. राहुल मैं तुम्हें कैसे भूल गया. अभी 3 weekly cisplatin प्लस रेडियोथेरेपी वर्सेस रेडियोथेरेपी, क्या डिफरेंस है राहुल? अभी तो एक ने 4% बोला, अभी एक ने 15% बोला. अभी क्या करें? चलो मैं किसी को बोलूं एक सर्च करो. हाँ शाश्वत इज देयर. शाश्वत ये दोनों में से एक डेटा डॉक्टर सरबानी घोष लश्कर का है, पब्लिश इन हेड एंड नेक कैंसर रैंडमाइज्ड ट्रायल फ्रॉम टाटा हॉस्पिटल. एक डेटा है डॉक्टर शर्मा का, अतुल शर्मा का रैंडमाइज्ड ट्रायल डेटा. मैं इंटरनेशनल डेटा की बात ही नहीं करता. लेट्स लीव दैट. फ्रॉम एम्स कोई सर्च करके बताएगा. उसमें यही है कीमो रेडिएशन दैट इज सिस्प्लैटिनम वर्सेस रेडिएशन. दोनों में वीकली यूज्ड है. मैं तो 3 वीकली पूछ रहा था. So let's take the number what was said. So it was said if you use only chemotherapy plus radiation, it can be sequential, it can be with RT, with can be chemo radiation, then number is 4%. The moment it changes to chemo radiation as a concomitant chemo radiation versus radiation, it changes to 6.4 to 8% depending upon which meta-analysis you want to take. But here that is not the question. The question what we want to know, cisplatin based chemotherapy with 3 weekly. What survival benefit we have, and then you're comparing with weekly, and that number is going to help you in taking those what is the non-inferiority margin. So for the sake of today's discussion, someone can argue with me later on. Go ahead, see this data. Two again, say one from Tata Hospital, one from AIMS. The absolute difference ranged from 15% to 20%. Someone said rightly when he mentioned. Now if you take a 15% difference, how do you go about non-inferiority margin? Last time we talked about hazard ratio. I'll be talking about another way. So you see the absolute difference. Then you take the confidence interval. So if you take around 15%, the confidence interval usually will vary from 15%. If you take it 8-9% to 20%, something like that. That is the average. So I don't remember offhand. That's what we had seen that time. Then what you do? The lowest part of it, you take it as an absolute difference in your margin. That is one way to do it. So if you have an absolute difference in 15%, you calculate the confidence interval for 15%, and I'm saying it average it will come out to be around 7, 8 or 9% to around 20%, and this is the 7-8% will be the cutoff for your absolute difference in the outcome, whichever measurement you take it as a non-inferiority margin. So this is another way to do it. So when you calculate This is one way you can calculate the sample size when your numbers are not huge. And last time I had shown the hazard ratio 1.5, and here I showed you 15% difference. And how did you come to 15% difference? This is what I'm saying. This is the way you go back to. So when we set the 15% difference, it is not absolute. It is upper boundary of the confidence interval. And what it means, most likely your absolute will come around 7 to 8%. I hope it makes a bit of a sense. Maybe we'll talk about some other way of doing also, in future. But this is just to you to learn. If you have thousands of patients, so when we say non-inferiority means what? If it's the 50% survival, assumption is second treatment is also giving 50% survival. No such trial is done. You will not be able to show me one trial which says we calculated no margins. After that, margin will depend upon what kind of question you're asking, what kind of endpoint you have, and third, what kind of number the patient you have. And then you're putting a safeguard at every place to see that your conclusions are fair at the end of the day. You're not harming the patients. So they have, what they do, these kind of study, what they have put a safeguard of what? Upper boundary of 95%. They didn't say it is absolute of 15%. That gives a safeguard that you have to calculate the absolute difference, and then if your numbers are less, if your confidence level is bigger, then also it will be seen that it is crossing the boundary. In spite of, think about this trial had for example, our trial from TMH had an absolute difference in 7% or 8%, and the boundary would have crossed 15%. Or think about difference would have been 5%. Then also, if the boundary would have crossed 15%, trial would have been negative. As a different matter, it was a negative study and it was supposed to be non-inferior. One more just conclusion, overall survival in our study also was similar in both the arms. So remember, local control was better, but there was something happening in 3-weekly arm which led to a bit more event, which led to similar survival. So this is for the non-inferiority margin. Anyone has a question on this or comment? If none, and these are ways to do studies, because if we can keep arguing what will be the difference, some will say 2%, some will say 5%, some will say 8%. But think about, we can keep saying 2%, do any study with 2%. By and large in life, you won't be able to complete a study, by and large. I'm not saying people have not done it. I do know that people have done it, those small differences, but by and large, studies are not done with 1 or 2% differences, because that is by and large not feasible, and we will not have answers to them. Because when we say non-inferiority, our understanding is 5-year survival of 50%, then also it means in the other arm also it should be 5-year survival of 50% or maybe 48%, but that's not the case. So I hope I made sense, and maybe hopefully it may help some of you in case in future you want to do some study. But in the meantime, if there is no comments and question, or if there is any, I'll be happy to answer from this point of view only. The rest we all discussed.
Sir, your comments when to select 3-weekly and weekly. Your final comments and suggestions for your students.
Weekly or 3-weekly. So what we understood, local regional control is inferior with 3 weekly of 30 milligram per meter square. Survival was similar. But local regional control is an important endpoint in head and neck cancer. As much we want survival to be the most important endpoint. So 30 milligram, we have a data from Tata Hospital, which showed that 30 milligram per meter square better than radiotherapy versus 30 milligram per meter square plus radiotherapy. Seeing our data will say if you can give 40 milligram per meter square, that should be preferred. But in case you can't give 40 milligram per meter square, you do have some indirect evidence for 30 milligram per meter square. So if you have to give weekly, 40 milligram per meter square, and if you can give 3 weekly, that will be more reassuring. So today also, if you can give 3 weekly, you will prefer it in spite of 2 trials coming up. But what it does, it is a bit of a practice confirming study that it reassures you that if you're using weekly and using 40 milligram, it is fair. Because Japanese studies also, as Nandini said, there are many issues. A trial running for 12 years had a median follow of 2 years. The trial had 60% patient having metastatic disease in the recurrence, which we have never seen. It is 10 to 15%, 20%, maximum is 30% across the world. So Japanese had something different. Third, they had 33 to 35% of patients who were margin positive. Ours were hardly 3%. It looks like their margin positivity rate is far higher than what we have. So there was issues which will concern people, and that's why the interpretation for me is 3 weekly. If you can give it, continue that. If you have to give weekly, 40 should be preferred, and that will be reassuring for you. But if you can't give it, give 30, because there's some data for it that you can give weekly 30 milligram per meter square also. But that's indirect data, that is in definitive setting. So that will be my interpretation. There was one query regarding small differences. Large sample size can provide statistically different. However, need to ask whether it is clinically meaningful. Small differences, large sample size can provide.
No, what I wanted to say, Dr. Kumar, was that I mean, if you can take a 20,000 patient sample size, even a 0.5% difference would prove statistically significant. But like whether that is clinically or not, that is something that I just kind of wanted to highlight.
Totally agree. That was a very fair comment by Dr. Jaya. What we are discussing here, how to answer a clinically relevant question in a way which is answerable in the clinic. And Anant has put a point that we have, as I mentioned last time also, we have 2-3 studies for non-inferiority design. One is a metronomic trial for head and neck cancer, which was published in Lancet Global Health, and another one is low dose gemcitabine versus full dose gemcitabine, both published. That is in Lancet Clinical Medicine, and people can read if they want, because that was implemented here. So it went through all the rigors to see that they are in the print, and those margins and the way this design was made, it was acceptable in the multiple forum. In fact, Dr. Nandini had presented that trial in ASCO as an oral presentation, so it was accepted as an oral with the same margin. And it will be interesting to know if someone asks me next time, metronomic chemotherapy non-inferiority margin, we'll be happy to discuss. That was discussed very nicely and at length in the IRB. I'll be happy to share what happened, how the discussion went, and what we learned while doing that. I'll leave it because I think so. We are 9:39. Lingraj, anything about COVID? Anything about COVID? Lingraj is not there. Lingraj was very active. How come he's not there? No, maybe he went to OPD. Dr. Jaya, last comment. Madam, I'll answer your last question, but after your comment.
No, I think presently the numbers are down, but we are hoping that they remain as they are, and we continue to take our precautions. Yeah.
Thank you, madam. And madam, comment was valid. Why 30 milligram in head and neck cancer and why 40 in cervical cancer? Madam, globally it has been 40 milligram by and large. Only some places it has been 30 in head and neck also, and we picked up 30, and 30 was based on, there was a study which compared 50 milligram flat versus RT, and the 50 milligram flat was better than the RT. And when we take our body's surface area of around patients, it comes out to be around 30 milligram per meter square. Not a very robust scientific basis for picking it up, but that was what was followed when I joined, and it has continued. That is the reason why that dose was chosen. But valid reason.
Thank you, sir.
But globally, I totally concede people have using 40 milligram per meter square in head and neck. But that also 40 milligram per meter square in head and neck, there has been no data, and that's why these trials were important. There has been no data how it comes in trial and how we practice. By and large, globally, except Western world, and that too in some areas, people have been practicing weekly with 40 milligram per meter square. The image study done in Indian patients, we should prefer 100 milligram till we get data for 40 milligram. So Mr. Ji's comment. Thank you, Mr. Ji. So with this, thank you everyone. Thank you everyone for nice discussion and debate. And we'll request next time students, as Dr. Lingraj suggested, you can be a bit more spicy. That debate makes things more interesting then. Thank you.